so this case was really interesting to me as well. We're just going to kind of dive right into it. I'm going to kind of run through the case itself and then a couple of teaching points, both things that I learned and things that I wanted to share with Edwin that hopefully were beneficial to him. So just in interest to save time, I'll make a quick disclosure. I don't have any financial or business interests which would bias anything I'm going to present today, but I do have some additional disclosures to make. I have been fortunate or unfortunate enough not to ever go to Africa to practice, although that is on my bucket list. I am not a specialist in tropical medicine or field or triage medicine, so that is not my area of expertise. I do not pretend to be an expert there. I have always practiced in tertiary children's hospitals with every available diagnostic and therapeutic treatment available to me with pretty rapid turnaround. So I am fairly ignorant of the conditions, and so please just forgive that ahead of time. I'm learning as I go with this. So this case was initially sent to me in June of this year. It was a 2.5-year-old male who had presented to the clinic with lethargy, weakness, and diarrhea. He came with his grandmother, who came with him because she was concerned about his level of drowsiness and fatigue. She had reported that he had had a self-limiting diarrheal illness a few weeks prior to the presentation that we're talking about today, but then recently in the past days prior to coming in had several foul-smelling non-bloody stools that were occurring about 5 or 6 times per day. She was also concerned that he was not eating at all and had a lot of fatigue and tiredness and was just not interacting as much as he usually does. So that was why they came in for the second visit. And as you see here, I've kind of narrowed down the positive and negative review of systems that was asked of the grandmother in regards to the patient. There's always a broad differential with GI illnesses, but when you put it in the setting of a developing country, the differential is just huge. And so for me as a practitioner, these were the most pertinent positives and negatives. No vomiting or abdominal pain is a really big thing to cover in terms of GI illnesses, especially in children, especially if they're pre-verbal or they're not talking yet. This child was kind of in a little bit of a pre-verbal stage, and so eliciting abdominal pain is really important. He hadn't really had high fevers, but he had maybe a mild fever that was a little bit subjective based on the data that I had initially. But he did have a lot of weight loss that was noticeable to his grandmother. Non-bloody diarrhea, not interacting as well. He had some constipation maybe between his first and second illness. Decreased urine output or oliguria is an indicator that we always look at in children to look at how dehydrated they might be. And then again, of course, a mild fever was also reported by the grandmother. The social history and the social aspect of this case was really interesting to me in terms of what Edwin could provide, because, as the clinician, I get what's written down on a piece of paper, thousands of miles away. I don't have immediate access to kind of the narrative behind the patient's presentation. So this is actually extremely helpful information in terms of deciding what to do with a patient, maybe even more so important than the initial presentation symptoms. He was unfortunately abandoned by his parents who were unable to care for him at 4 months of age, and his grandmother adopted him. She, from what I understand, sells fish, and they live in a very small hut and drank local lake water, and they had very sporadic poor clinic follow-up. He had been breastfed exclusively for 3 months until his mother was no longer able to care for him, and then was transitioned to what I like to call the beige diet, which is cow's milk, porridge, and potatoes. So all the kind of starchy, plain things that a lot of children, even in America, prefer, but this was what was available to him as provided by his grandmother. He did reportedly meet some important developmental milestones up until about 12 months of age, but we didn't have a whole lot of information on that. And his last weight prior to June of this year was 6 months prior and was about 10 kilograms in January, which will be pertinent later. He had some possible concerns for delayed milestones and poor growth, and his immunizations were not up to date. So you can see just kind of very poor history, unfortunately, which is, I'm sure, not uncommon, especially with as far as they had to travel to get to medical attention. And this is a photograph of the child kind of from the top of his head. I apologize, it's a little bit overexposed, but when I first saw this in the case, which was sent to me, I thought, gosh, this child looks teeny, teeny, tiny. He's 2.5 years old, and he's got these little itty bitty tiny arms and legs. You can kind of see that his hair growth is kind of sparse, and his hair looks a little bit almost kind of patchy. So anyway, it's not a straight on shot, but you can tell that he is quite small for his age. And if you look at his growth parameters there in the physical exam, when he presented for the second time, where we had a weight to refer to, he had dropped almost, over a third of his body weight. He had gone down to 7.2 kilograms, which is well below where he should be. He appeared lethargic, even though his temperature was normal and his breathing appeared normal. He had what we call delayed capillary refill, which is where, you press on the child's skin and you wait to see, if the color returns to the place where you press and it's delayed. That's actually a very good indicator of dehydration in both adults and children especially. He had very kind of dry, thin skin and kind of patches on his skin that were kind of light colored. But his abdominal exam, his cardiovascular exam, and pulmonary exam were reportedly normal. And in terms of his neurological exam, it was reported that he was lethargic, but otherwise appeared appropriate. So, that's what I was provided with. And this was actually really good for me. So as a pediatrician, first and foremost, I always look at growth parameters and what kids look like kind of just globally when I see them. And when you plot this child on the United States growth charts, obviously we use some different parameters than children in developing countries, but he would already be flagged at his initial presentation. The chart on the left would be his 2-year-old visit back in January, where he is below the 5th percentile. So he would have already been flagged as failing to thrive. And then if you look at the one on the right, he is falling way, way below where he should be in terms of his growth. So he is definitely a failure to thrive by American standards. But then if you look at what the WHO uses, is something called a Z-score, which is just something that looks at standard deviations of different measurements. This is just the weight for age. He was already almost 2 standard deviations below where he should be for his weight back in January, and then of course he dropped completely off the curve 6 months later. Acutely or chronically to his diarrheal illness, we don't really know because the follow-up was so poor. So my initial concerns about this patient were obviously, he is acutely and chronically malnourished, just based on the data that we had. And then on top of that, he's got this diarrheal illness where he's, dehydrated now. My initial thought when I read this case was that he had some iron deficiency anemia, which is something we will discuss. And so I kind of advised Edwin as such how to treat that. He also likely had several vitamin and micronutrient deficiencies, which I'll touch on just briefly in the teaching points. And then in terms of infectious concerns, now I didn't have all of the diarrheal information initially when I got the consult, but once that was kind of brought to my attention later, there is certainly a big concern for infection here, and his malnutrition also complicates that, as we'll discuss in the teaching points. So he's got a lot of different things going on. Unfortunately, his underlying malnutrition really does put him at high risk for a lot of things, especially infection. So at the time, not knowing what was available, I recommended that if they had the availability to get a CBC or a complete blood count to look at his level of anemia, specifically his hemoglobin, that they do that, although clinically you could diagnose him that way. Looking at his electrolytes and adding a blood culture if he, did in fact have an infectious problem going on. So the initiation of hydration, modifying his diet as best they could, and initiating either a multivitamin or iron supplements like ferrous sulfate were what I initially had recommended to Edwin prior to knowing about kind of the diarrheal complications. But of course, these are all going to be important just in terms of nutrition in general. And what they were able to do was surprisingly, not surprisingly limited. He did have a stool culture which showed he had an infection, a parasitic infection called Giardia. He did have some white blood cells in his stool. The labs that I had said would be helpful were not available, but that was not surprising to me. It did not limit their ability to treat there, and I was very impressed with the treatment plan that they actually were able to send back to me. He was admitted for treatment, diagnosed with infectious gastroenteritis, dehydration, and malnutrition, secondary to neglect. And in terms of the neglect, and Edwin's tape after I get done speaking will kind of tell more about this, but it wasn't necessarily that she was being intentionally neglectful. It was that she just didn't know what to give him, and just really didn't have the education that we kind of take for granted, especially here in the US, on what to feed a child in order to help them thrive. They did give him IV fluid boluses in order to kind of resuscitate him, which is exactly what I would have done in the emergency room. They gave him oral rehydration. They started him on antibiotics and antiparasitic medications and several different nutritional supplements, which is all very appropriate in this case. He was discharged on multivitamins, several nutritional supplements, and obviously close follow-up was recommended. So that was kind of the case from beginning to end, kind of as we know it. Follow-up is still kind of pending. What I will say is that I learned a lot more from this case than I thought I was going to. I had to read through Edwin's notes, and there were several things that I didn't know what the abbreviations meant. And that kind of goes back to what I was saying earlier. I practice in a first world country where everything is available, including 10 grocery stores on every corner. So I'm not used to dealing with acute severe malnutrition. I've seen a few cases of neglect, but those are far and few between. And so I had to actually do a little bit of digging myself on kind of how common is this and what are the treatments that are available. So for those of you that practice this regularly, forgive me, this is for those like myself who maybe are not as familiarized with what treatments are available. But malnutrition is obviously far more common in developing countries than it's going to be in the developed world. In fact, 1 in 4 kids in Kenya are what we call stunted due to malnutrition, and that's just their overall growth and development is just kind of poor, secondary to getting chronically malnourished, or not having those macro and micronutrients they need to build those really metabolically active tissues, the brain, the heart, the lungs, the bones, and then an even smaller percentage of them actually suffer from wasting, which is going to be that real severe kind of disease that you see in like the child in this picture, where they're just emaciated and they have protein enteropathy, and they have these big old bellies and these tiny little skinny limbs. It's actually less common than I thought after doing my research. It can affect not only growth and development, but actually their emotional and intellectual development. And at some point, these effects can be irreversible, which is why it's so important to address those as quickly as possible. And then, as I kind of alluded to before, having a deficiency in micronutrients and macronutrients, not only, it puts you at risk for several diseases, but infections, especially diarrheal infections, can be a lot more detrimental to children who are malnourished because of immunodeficiencies from malnutrition. So it was kind of a perfect storm for this child. And then just briefly, I had to look up what some of these abbreviations in Edwin's notes were. The RUTF and F75 and F100, for those of you that don't know, I didn't know, are these kind of super calorie and protein and vitamin and mineral rich fatty food supplements that can be like mixed with water, and they are equivalent to a huge amount of food, which is great. And it's what can be used in cases like this where a child really needs to kind of catch up on their growth. So that was an education for me. I know that's probably boring to some of you who know what this is, but I really enjoyed reading about it and kind of educating myself on what's out there and what's available. So the teaching points here, when I read this case, like I said, I was suspicious that this child was severely iron deficient. It's actually a very, very common nutritional deficiency that you see. We see it in the United States even. I actually see it several times per year, and usually it's going to be in my young toddler age kids who, like I say, love the beige diet. They like their fries, they like their cow's milk, they like nothing with vegetables, very little meat, and they will drink cow's milk all day long and come in with very similar symptoms and have hemoglobins of 3, 4, or even 5. I've even seen that. So it is not uncommon in the United States. I do see this, a couple times a year. So the child's clinical symptoms and his diet were very telling of what he likely had. Cow's milk is very low in iron. It can cause diarrhea if consumed in excessive amounts. Older females of childbearing age who are who have reached kind of their hormonal maturity can develop iron deficiency secondary to bleeding from their periods, but that's less common. And then in this particular case, and especially in third world countries, certain parasitic infections actually can worsen iron deficiency anemia because the parasites kind of live and thrive on iron. So they rob the patients of even more of their very precious iron stores. And just to remind everyone, I'm not going to be doing a biochemistry review, but iron is going to be central to your hemoglobin molecule. It's kind of I call it the seatbelt of the hemoglobin molecule, kind of binds everything together and allows the molecule to carry oxygen efficiently to tissues, the bones, the brain, all your metabolically active tissues. And you develop what's called a microcytic hypochromic anemia, where the red cells just become kind of mealy and pale. And they kind of lose their normal structure, as you can see there on the right from the histology slide. You've got normal and definitely AB normal red blood cells. So that's what you're going to see under the microscope or a smear. And actually, after making my recommendations in this case, I probably could have recommended looking at a peripheral smear, because you probably could have seen this. And that may be something that I look at going forward if I ever get another case like this. So that was helpful to me in reviewing this case. And iron deficiency anemia in children develops kind of insidiously, but it's really beautiful actually how the body sets this up. Breastfeeding is obviously a very important aspect of a child's early nutrition. We encourage mothers here and in other countries to breastfeed as long as possible. And this is especially important in third world countries where, other nutrition may not be readily available. Kids can absorb iron more efficiently if they're breastfed, but sometimes that's not always an option. So transitioning them to other sources of iron, like in formulas that are fortified with iron, is important. But what happens is, a child may transition from breastfeeding to something else like cow's milk. Right around 9 months of age is where we recommend kind of introducing table foods, mashed up bananas, cereal, things like that. So poetic how this works, because right around the time the iron stores in the body from breastfeeding and just being a baby are reclaimed is right around the time where you transition the diet. So it's kind of it can be a perfect storm if the child just kind of takes to one or two foods, some of which are not iron rich, and then just kind of goes with it, especially if they drink a lot of cow's milk. Then you get the iron stores depleted. You don't have the efficiency to carry oxygen to other parts of the body, so you get the almost immediate effects where you're going to get evidence of hypoxia, hypoxemia, and then downstream effects where you get growth retardation and emotional and developmental problems. So these are going to be the symptoms that you will see. And again, this was why we were able to diagnose this child both kind of clinically without the labs. In moderate to mild deficiencies, which is going to be a hemoglobin range kind of in the low 10, 6 to 10 range, you're going to see tiredness, exercise intolerance. You're not going to see paleness or pallor until around 7 milligrams per deciliter, which is about half or less than half of what we consider to be normal. And that's actually kind of remarkable that you don't get that paleness until about half of the normal. Patients can develop a desire to eat things that are not meant to be eaten, such as dirt, brick dust. I had a kid once that ate packing peanuts. That was what concerned his mother initially when he presented to me in the ER. And then eating ice, that's a big one actually that we sometimes will see in pregnant women who come in with anemia. So your later, more severe symptoms you're not going to see until your hemoglobin is dropping less than 5, which is a pretty remarkable number. You'll get thinning of the hair like this child had, anorexia or not eating. You can get what's called high output cardiac failure, where the heart is just pumping because there's hardly any oxygen bound to the hemoglobin. So it's having to crank out more volume in order to get oxygen where it needs to be. And so you may even hear these really high pitched systolic murmurs on physical exam. And then, impaired neurological function if it's really severe. So this child definitely, I think, would fall into the severe category just based on his clinical symptoms. which is why it wasn't hard to diagnose him clinically. Treatment and prevention, these are some of the recommendations I made to Edwin initially. Obviously, I alluded to breastfeeding as long as possible, because obviously breastfeeding is the perfect food for an infant or a young child, but up until about a year of age, if that can be managed. If not, iron fortified formulas are important. In toddlers, you want to try to limit their cow's milk intake if possible to less than 24 ounces a day. And I tell parents, obviously, that's going to be like 3 sippy cups worth. That's kind of how I put it in perspective. If you can supplement with iron-rich foods, that's going to be your spinach, which I know all kids love, meats and seafood and shellfish, which actually this child did technically have access to. The grandmother just wasn't able to afford meats and such. Those are all going to be good foods you want to try to incorporate. And if needed, supplementing with ferrous sulfate solution or tablets can be helpful as well. You're going to want to start with a dose of 3 to 6 milligrams per kilogram of elemental iron. That's what we look at in terms of dosage, and it needs to be divided 2 or 3 times daily. And I did caution Edwin when he initially consulted me that iron does have some gastrointestinal side effects. I frequently will have patients complain that they're either constipated or have diarrhea, that their stomach hurts, and they'll actually stop taking it because the side effects are so unpleasant. So that's not something that's uncommon. And also, if I'm prescribing iron to patients that are really young kids, I also caution parents that if kids get a hold of these, bottles of iron or solutions, that it can be very toxic in large doses. So they want to make sure to keep that, up and away from the child so that they don't get a hold of it and get a whole different problem going on, where the solution can be worse than the problem. And then in cases of severe anemia or heart failure, you can consider red blood cell transfusion and iron infusions, but with red blood cell transfusions, you want to be very careful because these patients do not get to a state of heart failure quickly. It's a slow, insidious process. And by giving them red blood cells, you kind of shift their physiology, or can shift their physiology, and actually precipitate a congestive heart failure with the fluid overload and kind of the rapid physiologic changes. So, that's something that is, not what you want to do unless you absolutely have to. And then just as a small aside, vitamin C, because it's so wonderful, is actually kind of a cofactor for iron. So in cases where you're going to prescribe oral supplements, you may want to consider a vitamin C supplement as well, just to help with increased absorption. So get your orange juice in there if you can. And then a small aside, and then I'll hopefully be open for questions. I actually looked up vitamin A deficiency in my reading about malnutrition. I actually learned that vitamin A deficiency is super common in certain parts of Africa and the developing world. It's the most common vitamin deficiency in Kenyan children. I am less well versed in this because I don't see this where I live, but it actually made sense to me in my reading that this child would be severely vitamin A deficient because it usually happens as a result of low fat in the diet and then parasite infections, which I have been told is very common in these children. It can also increase your risk for measles infection and complications. And for somebody that lives in a country where measles vaccination is routine, it's also something that I had to think about as well with this patient because, I don't believe he was vaccinated against the measles. So there's always that threat there. Vitamin A deficiency is associated with a higher mortality in young children in developing countries. And this was kind of shocking to me in my reading that supplementation with vitamin A that's preventative in countries where malnutrition is common can actually reduce childhood mortality by up to 23%, which is a huge number, and is actually recommended by the WHO in countries like Kenya for children who are at risk for malnutrition. So that was actually really interesting for me to learn, and it is yet another point I took away from this. And just briefly, this is the symptoms that you see with it. I don't believe that this child had these ocular findings, but essentially you do get thinning of the hair and nails, which I think he had thinning of his hair. Night blindness is one of the hallmarks of vitamin A deficiency. You'll get skin changes, fatigue, problems with your immune system, poor growth. And then the ocular finding you see here is something called I think it's a bitote spot. It's French. It's essentially where you get keratin deposits on the cornea that's slowly kind of drying up. secondary to vitamin A deficiency. It's a kind of a zebra physical exam finding that I've never seen, but I would imagine that some of the practitioners in Kenya and Ethiopia have probably seen this in severe cases. And then treatment is fairly simple. It's an oral supplement that is recommended 100 to 200,000 units that's given in different frequencies for different age groups. So it's fairly straightforward to treat. And they did, like I mentioned earlier, start that supplementation for this child. So I'm going to try to wrap it up and open it up for questions, but I did want to share kind of my experience just briefly so far with this. I have very much enjoyed my experience so far with the Addis Clinic. I actually was told about it by a friend of mine, Dr. Donna Perlin, who is one of my colleagues where I work. She is amazing and said, you know, I think you would be into this. I'm about to finish some maternity leave and go back to work, and I took this on, you know, not knowing what to expect, knowing that I would be limited in my education as to what is available halfway across the world. But I wanted to try it out to see, and I really enjoyed it. You know, some of the things that make these cases challenging are obviously going to be things that you think about. Telemedicine is not, you know, hands-on medicine. You can't reach through your computer as much as I wanted to do that for this child, you know, and slam an IV in him and admit him for malnutrition and do all these things. You can't do that. You know, the information that I got was kind of broken up by time, and the follow-up was, you know, a little bit broken up, but that's just how it is. I mean, you know, they're out there working as fast as they can and getting good turnaround as you know, to the best of their ability. And so, and me as an ER doctor, I'm impatient. I'm used to getting things within minutes of asking for them, you know, labs and such. And, you know, having to kind of wait and get that delayed gratification, you know, is challenging. But I was glad to hear that they were able to treat this patient actually far beyond what I expected them to be able to treat him with. Obviously, there's diagnostic and treatment limitations. I wanted a CBC. They weren't able to get it. But you know what? Totally fine. The clinical information I had was more than enough, which I think also speaks to the importance of the physical exam and kind of the lost art of the physical exam and just looking at the patient. So I think Edwin did a beautiful job, you know, kind of communicating what he saw in this patient to me, even though there were, you know, electronic limitations. And then, of course, the follow-up with this patient, less than ideal because of lots of reasons, I'm sure. Family has had trouble getting to care due to transportation issues, monetary limitations, etc. But the follow-up that I have been able to get so far has been very satisfying, and I really enjoyed being able to help on this case. It was an education for myself in more ways than one. So, you know, I know that Wade, you're very appreciative of the help that we provide, but I have learned so much so far in the few months that I've been involved with the clinic. And I just want to thank you and everybody who's involved for, you know, giving me this opportunity. And, you know, with that, I will turn it over to questions. I'd be happy to answer what I can. And thank you guys very much for your attention.
Thank you so much, Evan. If anyone has questions, just navigate to the lower left-hand corner of your screen and unmute yourself. I have a question just to get things started. Evan, you, in your initial diagnosis when you're consulting on the case, I wonder if you used any other resources other than the World Health Organization to help contextualize the situation for you, since you had not traveled overseas. What other tools and resources would you maybe suggest for other physicians participating?
You know, WHO was very helpful. I actually looked into UNICEF as well. And believe it or not, I actually consulted some of my colleagues who have been to these countries. Like I said, I'm very new in my career, especially at this. I am novice at best. And so I actually did some phone calls to a couple of my other physician friends who have done this type of work. My mother actually has done several trips to Ethiopia. And so I had to actually call her. So, you know, those were kind of the resources that I started to use. And then my infectious disease colleagues, actually, I have talked to some of them as well.
Thanks so much.
Thank you very much for this presentation, but I didn't get your name. so I can address you properly.
Oh, it's okay. It's fine. It's Evan Ali. You can call me Evan. That's totally fine with me.
Evan, okay,
Yes, yes.
that's awesome. Yeah,
Mhm.
I'm from Nigeria, so
Okay.
I'm very conversant with. I live in the United States. My family immigrated here over 40 years ago, so I'm very conversant with some of what you have experienced in Kenya, and I applaud you really for what you've done. But here are some issues that I'm not sure if you are aware of.
Yes.
One of them is when cow milk is recommended to the children, what is the source of water for mixing the cow milk to make it here? Most of for the person, the people you worked with may give you some information, but that predisposes children also to parasitic diseases, like you just mentioned, the Giardia lamblia, or some other kind of parasitic disease. And so people usually ask them to boil water, okay, before they mix it with the cow milk. Now, to boil water, you have to have firewood or stove or coal or something else. Okay, and then they boil the water because the water is hot and the child is really hungry. They then mix it with cold water to cool it. Okay, so
And that's not sterilized water then.
and it's not sterilized
So it's like
water.
it defeats
Yeah.
the purpose. Yeah, yeah. No, that's
So
actually excellent. Oh, I had no idea. When I thought of cow's milk, I thought to myself, well, are they getting it directly from a cow? And do they have a cow, or is it powdered milk, which I think is what
it's
you're alluding to?
powdered. It's
Okay,
usually
that's good
powdered
that's
milk.
actually really good for me to know because that's an
Yes,
additional source of infection. So, how
yes.
common is it for people to have access to an actual milking cow? I'm just curious.
People do have access to cow milk, but it's not usually sterilized. So
Right.
that's even worse than
Yeah.
just getting the powdered sterilized milk. And then one that is fortified with iron.
Yeah.
When they get the milk, the cow milk that is sold commercially, they get more nutrients, so to speak. And when they drink the one directly from the cow, they're more prone to catching other kinds of diseases.
Yeah.
So, but I'm very, very impressed with what you've done with little knowledge about the environment and the area and the infrastructural problems, logistics problems, time delays, and all that. I applaud you. Thank you. We need you.
Well, thank you very much. And thank you. That information is actually super helpful to me. Because again, I guess I should have thought powdered milk because obviously refrigeration is going to be an issue as well, but
Yes,
that is definitely something I will take into account for sure.
yes, yes. And most
Thank you.
of these people you're talking about don't have refrigerators. They're lucky if they have power,
Right.
2 hours a day. So.
Excellent.
Thanks so much. Any other questions before I head over to a video of Edwin describing the situation?
I- Evan, nice to meet you. Katie Cahill here. This is a question perhaps for you and perhaps Wade and maybe Edwin will provide some follow-up on this. But I learned a lot about the sort of available food calorie sources and resources that they had available on hand to address malnutrition. I'm curious, longer term, beyond the sort of acute hospital admission or clinic admission, do you know what was provided to the family or what was going to be made available to the child to ensure 6 months, a year from now, that the growth trajectory was going to be moving in the right direction?
So that is a great question. And I can tell you kind of based on the limited follow-up I have, they have unfortunately missed another clinic appointment, which not surprising. Yeah, I believe they were discharged with some of those, like the F75, F100 formulas and the multivitamin. Beyond that, I'm not really sure. And that would actually be an excellent question for Edwin, if he could answer it.
Right. And it's 3 o'clock in the morning in Kenya.
Yeah, it's early there.
But I did have a conversation with him 2 days ago, and it was very insightful for me. Edwin is employed in a private clinic, and it was previously funded by International Planned Parenthood to treat HIV/AIDS patients and mothers with children as well as orphans. So they had a very limited scope of care, and Edwin was the only clinical officer employed by them. They have recently lost their funding. Fortunately, he's worked with us for a year, and so we've employed him part-time to assign some of these telemedicine cases to our volunteer physicians. So that's a little background. But what he did tell me is that this family, because the grandmother is a fishmonger, had access to an iron-rich fish called a dega, which I've eaten on Lake Victoria with Edwin the last time I was there. They could not afford chicken and beef, so they supplemented that with this fish. Spinach is available there as well as pumpkin leaf. So some of the treatment plan and the follow-up that Edwin provided to the grandmother was about a proper diet. And in the first instance, when the child had lost so much weight, they began iron supplements, a new diet, and the child was improving. When the child regressed, it was because the grandmother thought everything was fixed, and she returned back to work. And so she had lapsed a little bit in the treatment and the revised diet for the child. They did miss the most recent appointment, but in the interim period, Edwin, based on just the first consultation that he had with Evan, learned a lot about iron toxicity. And when the child presented with diarrhea a second time, he was able to assess from the first consultation without having to reach back out to the Addis clinic. He learned that he needed to just stop the iron supplement that he was providing. And so he's got a lot of hope for the child and for this family going forward, because they do have some available iron-rich foods to include in the diet.
Hi, Wade, Pam here. I would thank you, Evan, for presenting on this. To me, it sounds, there are a couple of things that strike me. One is it's a social service kind of case. I don't know that the home environment was the greatest for this boy. You know, Western Kenya, as you just said, has lots of, you know, dark green leafy vegetables and plenty of fruits that have orange fruits that have vitamin A. It's not impossible to get much better quality of food for kids. I kind of wonder whether maybe he would have been better served, I mean, I hate to say this, but in just a Ministry of Health clinic, because they deal with malnutrition all the time, and they have really well developed protocols and approaches. There's something called CMAM, Community Management of Acute Malnutrition. And I mean, it's exactly what you described with the, you know, the ready to eat plumpy nut, ready to eat foods and supplementation and everything. So it's not as if it would be different, but it seems to me it would be a locally available kind of treatment in a public service clinic.
Right. So,
and these are government run? Are these clinics government run then? Okay.
Yeah.
The one that Edwin is in is private. The nearest public facility to the west is Siaya, and to the east is either Kisii or Kisumu. And based on what I heard from Edwin, is that the grandmother one, she couldn't afford chicken and beef, so I do not think she would have been able to afford the public transport. She felt more comfortable with Edwin and that clinic, I think, due to proximity. It's right on the lake. Tomorrow I'll post on Facebook a video of the clinic. So it's very close to probably where she works, and it sounds like she felt the pressure to be at work. So I think that's probably why they did not travel to the ministry.
Yeah, I mean, it just surprises me a little bit. I mean, what did you say it was, Migori or Homa Bay? Where are they?
Homa Bay.
Homa Bay. I mean, there are primary level clinics pretty close, you know, pretty scattered around. I'm just surprised there wouldn't be one that she could get to pretty easily. And if she's selling fish, why doesn't she, yeah, fish would be the answer. Forget the chicken and beef, you know.
Yeah.
Anyway.
Thanks, Pam. Anyone else before we see a short video from Edwin? All right, I'm gonna share this short video and then we'll close this out.
I'm Edwin Wara, a senior clinical officer in Allie County. The case that has just been presented by Dr. Allie was actually my client. And through Dr. Allie, I got a lot of knowledge that actually we can get to identify features of iron deficiency anemia clinically. We were not in a position to do a complete blood count, but through Dr. Allie's help, we managed to make the diagnosis and the management of this type. She gave us a guideline on what to do. In our guideline, there were some things that the grandmother was not able to afford based on the social history. For example, she mentioned that we can introduce the child to beef, chicken, and some of the protein-rich diet and iron-rich diets that the grandmother was not able to afford. But being a fishmonger, we encourage her to use the daga. We encourage her to use the locally available leafy vegetables like the spinach that she is able to afford. Fortunately enough, our clinic also helped her to get some of the iron-rich vegetables. We gave her the beans that we believe is really going to help this child gain his weight. And coming back to our follow-up revisit clinic, I believe this child is going to come back with a better weight compared to the one that we received him initially. Great work from Dr. Allie. I'm very grateful.
All right, so that's the follow-up from Edwin. As these things happen on medical trips, medical mission trips all the time, there's bidirectional learning. So Evan learned a lot about the context in which we're operating right now, and Edwin learned some valuable clinical insights. And so I think he is now prepared to identify severe acute malnutrition when that's presented in the future, and may be able to help more children in the future. So if there are no further questions, we can close out this night. Again, be on the lookout in future emails from us. We'll post this video on our new and improved website, as well as information about our new monthly giving program called the Academy, where we'll support Edwin on his journey to increase technical skills and clinical skills through the Addis Clinic and through great volunteers like Evan and many of you. But thank you all for joining us, and thank you especially, Evan, for taking the time tonight. Everyone have a great night.
Thank you all for listening. Have a good night, everybody.